I'm Eric Youngstrom. I'm a professor of psychology and neuroscience at the University of North Carolina at Chapel Hill. And I'm also the co-founder and executive director of Helping Give Away Psychological Science. And you are here for another one of our wonderful speakers in our speaker series. I would like to start by thanking the Student Government Association of the University of North Carolina at Chapel Hill for their generous support to make this talk possible, and Phoebe Rada and Julia Bondareva for writing the grant proposal that student government funded. I also would like to thank Dr. Andrea Young, who is an assistant professor of psychiatry at Johns Hopkins University and an assistant dean there as well, for making time in her ridiculously busy schedule to come do this talk with us. Dr. Young and I have known each other. We were reminiscing as we were getting ready for this. We've known each other for more than 10 years, and I don't know how she feels about me, but she's one of my favorite colleagues. I first started working with her on a multi-site huge grant, longitudinal assessment of manic symptoms. And I remember when one of my colleagues introduced her to the team and said, "This is a wonderful postdoc. Remember this person. She's going to do great things." Not wrong. We have worked together for the entire 10 years in a bunch of different capacities. I've had the privilege of being a co-author on multiple papers, some that I'm playing a medium or large role in, and some that she's leading the charge and doing a really, really good job. So it's been a joy working with her. A joy learning more about her research, because she's been doing a lot more than a little slice that I knew about from the stuff we were doing together. So without further ado, I would like to introduce Dr. Andrea Young, and let's hear her talk. Thank you for doing this.
Thank you so much, Dr. Youngstrom. You're also one of my favorite colleagues and collaborators, and I'm really appreciative of the invitation. And thanks to HGAPS and to the student government for inviting me. I really appreciate the opportunity to talk with all of you. I am going to share my screen again. Okie dokie. All right. Hopefully you can see everything still. Okay. So I'm really excited to be here to talk to you today about racial and ethnic disparities in children's mental health services use and potential solutions. So here are my disclosures for the past 3 years. You can see where I've gotten some research support. I've been lucky enough to be on the board of directors for HGAPS, and I'm on the editorial board for 2 APA journals. So today, our objectives are to describe racial and ethnic disparities in access to children's mental health services, to identify social structures that present barriers or facilitators to children's access to healthcare, and identify 1 to 2 strategies to help improve equitable access to children's mental health services. So we're going to do that by first reviewing a brief background and history of health disparities, including contributors to disparities and the impact of racism on health. We'll review some of the research that I've done on racial and socioeconomic disparities and access to care. And we'll talk about possible solutions, including for research and practice. But first, I want to do something a little bit different. And that's start with a case study. And it's not that I haven't presented case studies before, but this time the case study is me. So I've been doing this work. You know, a lot of times it's helpful to present case studies, but it's really hard to present case studies when your research is focused on service use, because you don't have cases when the case doesn't become a case. And so I was reflecting, I guess I'm a really great example of me search, but I was reflecting on my own childhood and some of the things that I experienced in childhood, and having conversations with my mother about the choices they made around engaging the children who were in their care and mental health care. And I wanted to share a little bit with you about my story. So this picture here is me. I think I was about 9 years old, and I think in this picture in 5th grade, I was at a parade representing the safety patrols. So by this time in my life, it was pretty obvious to my parents and to other adults in my life that I had some quirks. That's how my mother described it when I was talking to her about me as a child. She said, you were just really quirky. But using the knowledge that I have now, I know that those quirks would be best characterized as OCD. So having to make any decisions other than the most perfunctory made me freeze and feel really panicky. Things had to be organized a certain way in my room and other areas of the house. I distinctly remember spending lots of time reorganizing the Tupperware cabinet. And every time we took out Tupperware to put leftovers away, I had to go and reorganize it to make sure everything was aligned the right way. I had to closely follow every rule, and I had a lot of trouble when other people didn't. Cue the safety patrol. I actually, the requirements for being a safety patrol in my school were that you had to be a 5th or 6th grader, but none of the older kids on my school bus wanted to be a safety patrol. So I very eagerly volunteered to make sure everybody was following the rules on the bus when I was in 4th grade, and they let me do it. I was a perfectionist, and these symptoms first started for me around age 4, maybe a little bit earlier. I think my mother first noticed it when my younger sister was born, and shortly after my younger sister was born, and there's about 3 years between us. I have a family history of mood and anxiety disorders, and so my family had experience with mental health providers. That wasn't the idea of seeking mental health care was not foreign to my parents. But typically, any interaction they'd had with a mental health care provider had been with somebody who was of a different racial background. And when I recently talked to my mother about her experiences as a caregiver, she noted that for my siblings or my cousins for whom my parents were guardians at times, there were definitely times when it was clear that professional help was warranted. But after starting care, it often didn't feel safe or comfortable to remain in long term. She felt like providers often misunderstood her. She felt judged. She just didn't feel that there was sort of a good understanding of what my siblings or my cousins, my family was going through on the part of the providers. So for me, my parents decided that they were going to do their best at home. And luckily for me, their best was pretty amazing. So my mother wouldn't accommodate my compulsions by making decisions for me. I didn't say, I told you that was me in the picture, but that's my mother standing next to me. That's my mother at the safety patrol parade with me. But my mother, she wouldn't accommodate my compulsions. She'd give me a time limit to consider my options and make a decision. My parents helped me to identify healthy coping strategies to use when I felt panicky or overwhelmed. They helped me to identify my strengths and made sure I was using them in healthy ways. So in short, I was very lucky because my parents turned out to be excellent CBT therapists without knowing it. But what I'm hoping we can talk about today is how we as trainees, as mental health providers, educators, researchers can do better. For families of color like mine, who for generations have experienced discrimination and oppression, seeking professional care can feel and be riskier than it should. My parents shouldn't have had to make what felt like a really difficult choice. It shouldn't have felt unsafe for them to seek mental health care. Our care settings feel less welcoming, understanding, and validating than they should. And I'm going to use my mother's words because I think she put it really well. So she said, our history being people of color, particularly Black people, is such that if there's a problem, especially with your child, you use the tools you have, especially if you're not sure if seeking professional help is going to do more harm than good. So today, I want to talk about how we can do more good consistently and equitably. Okay, so just reorienting you to the overview here. I'm gonna continue by sharing a little bit about the background and history of health disparities. Okay, so most of what I'm going to share as far as background here is not going to be news to any of you, but epidemiological studies show a high prevalence of mental health problems, but pretty low service use among kids. And we know that receiving adequate care, adequate treatment in childhood is related to not only reduced current impairment, but also the reduced likelihood of having mental health problems later in life. So it's really important to make sure that kids get adequate treatment as soon as possible. Unfortunately, there's lots of evidence of disparities in access to children's mental health services, including disparities by socioeconomic status, parent education, family structure, race and ethnicity. These disparities in access to both mental and physical health care are well established. So youth of color are less likely to initiate treatment, they're less likely to stay in treatment, and they're less likely to receive adequate care once they're in treatment. So even those youth and families who are able to overcome potentially significant barriers to initiating services continue to experience barriers to remaining in treatment or to receiving adequate care. So the history of discrimination in mental health and disparities are longstanding and rooted in a history of racism and discrimination. Both the organizations, but the most relevant to this group, the American Psychological Association and the American Psychiatric Association, recently acknowledged their roles in perpetuating racism and discrimination, and have both issued apologies. I think apologies are really great starting points. The APA has also committed to a purposeful intervention into ensuring that APA, the field of psychology, and individual psychologists are leaders in both benefiting society and improving lives. They've outlined some specific actions that they're committed to, including prioritizing efforts in knowledge production and scholarship, including culturally diverse knowledge production, prioritizing efforts in training, opening pathways and workforce development, and prioritizing efforts in clinical practice and health equity. So one thing that people ask, it's like, okay, so you keep talking about how these disparities have been longstanding. We've known about, these problems for a long time. There have been some new policies put in place and strategies to help improve disparities. So like, what's happening over time? Are disparities improving over time? The short answer to that question is no, unfortunately. So this is a study by Cook et al. In 2017. This is actually an adult sample, but looked at access to mental health care between 2004 and 2012. And they found no reductions in racial or ethnic disparities in access to mental health care across that time period. And for Black and Hispanic adults, the disparities were actually exacerbated over this period. There's been a recent paper published 2022 looking at in a nationally representative sample of youth. And so this first panel here is any mental health care by race and ethnicity. So I know it's really tiny, it's hard to see, but this blue line is represents white youth, the orange line represents Black youth, and the gray line here represents Latino youth. And the first panel is any mental health care. The second panel is any outpatient mental health care, and then the third panel is any psychotropic medication. And so you can see, again, even looking at child samples, the disparities also aren't improving over time. So there were disparities between Black and white youth and Latinx and white youth in both the, so I apologize. So they looked at 2010 to 2011 up to 2016 to 2017. So there were disparities between Black and white youth and Latinx and white youth, both in the 2010, 2011, and the 2016, 2017 periods for any mental health care use and for any outpatient mental health care use. Looking at the psychotropic medication prescription fills, there were disparities between Latinx and white youth for both time periods, and for between Black youth and white youth for the 2016 to 2017 period. So the disparities between Black and white youth for any mental health care use and for any outpatient mental health care use were significantly exacerbated between that initial period they were looking at 2010 to 2011 and the 2016 to 2017 period. I want to also note that, I mean, this next study that I'm sharing, Bridge et al. 2023, doesn't directly look at the link between service use and suicide, but I just want to note that there are not only disparities in access to care, but there's some concerning disparities, increasing disparities in outcomes. So Bridge et al. Looked at youth suicide during the first year of the COVID-19 pandemic. This was a national study that suggested overall increase in youth suicide deaths across actually the first 10 months of the COVID-19 pandemic, but with some variation across racial and ethnic groups. That was particularly striking, with non-Hispanic, American Indian, Alaska Native, and non-Hispanic Black youth experiencing more suicide deaths than predicted. So again, not just disparities in access, but there's also disparities in outcomes, and that suicide rates are increasing at a disproportional rate for some youth of color. So I wanted to let's talk about the impact of racism specifically on health and well-being, but I want to first define racism. I'm going to use the definition that we used in a review paper that I was lucky enough to be a part of with Youssef et al. 2022. And the definition of racism that we used is a system of oppression that categorizes and stratifies social groups into races, devalues and disadvantages those considered inferior, and differentially allocates to them valued societal resources and opportunities. So categorizes people, devalues them, and then differentially allocates resources. So many racially and minoritized youth experience racial discrimination and victimization as early as the first decade of their lives. And racial discrimination negatively impacts the health and well-being of minoritized youth and can create barriers to accessing care. So I want to briefly review some of the literature on how discrimination or racism, linking discrimination or racism, experiences of racism to youth health and well-being. Recent studies. So this first study, Proctor et al. Examined discrimination in mental health in a sample of African-American and Afro-Caribbean youth. And using this nationally representative sample, they found that 90% of African-American youth and 87% of Afro-Caribbean youth experienced discrimination. And discrimination was significantly associated with lifetime and 12-month major depression and lifetime and 12-month anxiety. And this next study examined COVID-19 racism and mental health in Chinese American families. Nearly half of the parents and youth in the study reported having been directly targeted by COVID-19 racial discrimination online, which I find truly remarkable, half. And higher levels of parent and youth perceived racism and racial discrimination were associated with poorer mental health for both parents and youth. And then this last example that I want to share, at Park et al., they took things a step further, which I'll explain in a second, but they examined racial and ethnic discrimination in mental health in Mexican origin youth and their parents. And so what they found was that among Mexican origin youth, experiences of discrimination were associated with depression, similar to the other studies that I've just discussed. But again, they took it a step further and they looked at intergenerational discrimination and found that fathers' experiences of discrimination actually exacerbated the link between discrimination and depression for their children. So not only does experiencing racism or discrimination impact your own health, but it can impact the health of your children. So just making the point about sort of these intergenerational effects of experiencing discrimination. So I want to talk a little bit more about the systems in place that contribute to health disparities. So some of the, other than sort of like, obviously there's a direct impact on health and well-being of experiencing discrimination as a stressful life event and potentially traumatic event. But there are other mechanisms for how disparities might impact health and well-being. So again, we talked about racism being a system of oppression that differentially allocates valued societal resources. And so a lot of these differentially allocated resources contribute to worse health outcomes or impact health and well-being. So they're differentially allocated economic stability. There's disparities in access to employment, things like fair loan rates, income. There's a differential allocation of neighborhood and physical environment resources, so access to housing, again, going back to the loans situation, transportation, having access to parks and playgrounds. There are disparities in access to education, to quality education. There's disparities in access to quality food. So as we talked about before, because of a history of racism, economic resources are inequitably distributed, which puts people of color being more likely to live in low-income neighborhoods, and low-income neighborhoods are less likely to have things like grocery stores and healthy food options, which can obviously have direct impacts on your health and well-being. There are disparities in access to community and safety and other social resources, and to include things like support system, community engagement, policing, and justice policy. All of these things can impact health. And most directly relevant to the conversation we're having today, there's inequitable access to the healthcare system, including healthcare coverage, access to linguistically and culturally appropriate, respectful care, and differences in access to quality of care, which I'm actually going to talk to you about some of my work in that area specifically in just a little bit. So again, thinking specifically about mental health, there are inequitably distributed financial and logistical barriers, including there's research showing that there's some logistical barriers, including differences in logistical barriers, including things like the distance from one's home to a treatment facility, the availability of appointments at times that work for families, or difficulty taking time away from work to attend appointments. There are systemic barriers like provider bias and the relatively smaller number of mental health care providers that practice in areas that are more populated by people from minoritized racial groups. And there's also stigma and knowledge of mental illness that frequently have been investigated as contributors to disparities in access to healthcare, but actually only typically explain a small portion of the disparities in access to mental health care. So I want to move on to talking a little bit more about some of the work that I've done in this area. So I'm going to review some of the research on racial and socioeconomic disparities that I've done in access to care. And Eric mentioned the LAM study briefly earlier. It's a study that we've both been involved with, that I was lucky enough to be a part of when I first started at OSU as a postdoc in 2012, and have continued to work with this data. And I know this slide is busy, but I want to just highlight a few points to orient you to the sample that I've used for the two papers that I'm going to describe to you today. So both of the papers that I'm going to describe use data from the Longitudinal Assessment of Manic Symptom Study, or LAMS, which was a naturalistic design. And the important thing to know about the sample is that all of the kids in the sample were help seekers. So they were recruited during their first visit to one of 9 outpatient clinics that were associated with one of the 4 LAMS partners. LAMS has collected longitudinal data on 707 youth in the study who were between the ages of 6 and 12 when they were recruited. The sample is screen enriched for elevated symptoms of mania. That means kids were selected for having symptoms of mania. That does not mean that they were all manic. It means they had symptoms like having a lot of energy, having trouble sleeping, things like that. So actually, I think about 75% of the kids had ADHD, and maybe something closer to 20% had a bipolar spectrum disorder. But again, this is a really great data set of help seekers, all kids who have at least had a contact with a clinic, with really great, detailed, valid, reliable methods to measure diagnoses, psychosocial functioning, and children's mental health services use. So there had previously been fairly little research on service use in large samples across multiple sites. Not as much research on treatment retention compared to initiation, and not a lot of research on barriers to engagement. So I wanted to examine racial and ethnic disparities in retention and treatment, and identify other socio-demographic contributors and barriers to retention. With the specific questions, do race, ethnicity, socioeconomic status, caregiver education, child diagnoses, other characteristics predict treatment retention over 12 months? And I had an additional question of whether parents' perceptions of how well they were reporting the treatment matched their child's needs contributed to whether they were retained in treatment above and beyond the child and family characteristics. So just to orient you to what I'm talking about when I talk about services and retention and treatment match. So the mental health services that we were focused on here included outpatient psychotherapy, medication management, or their combination. Retention was defined as continuing to use whatever they were receiving at the baseline appointments at the 12-month interview. And treatment match was that caregivers reporting how well the treatment their child was receiving, how well their outpatient treatment was matching what their child needed. And caregivers rated this as not at all, somewhat, or very well. So what we found was that at baseline, 92%, so most of the kids in the study were receiving outpatient medication or psychotherapy, but only a third of the caregivers of kids who were receiving outpatient mental health care reported the treatment match or described the treatment match as very well, characterized it as very well, which is lower than we would want to see. 523 of the kids in the sample had service use data at the 12-month follow-up, and 68% of those continued to use baseline services, which I thought was pretty good. So almost 70% of the kids continued retained in treatment. So what was associated with treatment retention? I'm going to talk about this on a little bit more on the next slide, but just showing you the numbers here. So race was associated, parenting stress, and treatment match were associated with treatment retention. So being a person of color, being a child of color was significantly associated with treatment dropout. And this was even after controlling for caregiver education, income, and other clinical and demographic variables. So a lot of times when we talk about racial disparities, there's the question of, well, is it just better accounted for by socioeconomic status? And in this case, it wasn't. So even taking into account all of those variables, there was still a racial disparity in retention. And it persisted even after adding treatment match. So there are obviously some barriers that were not examined in these analyses that were contributing to treatment retention. The parenting stress finding is pretty consistent with previous research. Usually the things that bug parents are the things that they tend to seek treatment for. But I thought that the treatment match finding was an interesting one. So parents, so their perceptions, I call it attitude, but their perceptions of how well the treatment their child was receiving, this is pretty early in treatment, how well the treatment their child was receiving matched what their children needed, seemed to be an important indicator of their likelihood to continue treatment. So even families who overcome barriers to initiate treatment, again, face significant barriers or further barriers to continued service use. I think the implications of this are that, you know, as clinicians, we really need to be careful to be sensitive to parents or caregivers' opinions and cultural differences that might affect engagement, which we tend to think of as practicing cultural humility. And I'm going to talk to you a little bit later about a specific tool to use to facilitate these discussions, including a tool that will help to carefully assess families' treatment barriers early in treatment. And it's also important to discuss treatment plans with parents, making sure you're incorporating their opinions into the treatment plan when it's appropriate, and explaining the rationale for selected treatment modalities and offering a choice when possible. So the next thing that I was interested in was, so we know that there are barriers to initiating care, and there's barriers and disparities to staying in treatment. But simply looking at retention alone wasn't really getting at what I really wanted to know, which is what are the correlates of receiving good care? Like who's getting good care? Are there disparities in receiving adequate care? So that gets a little bit trickier to look at, but with the help of some really great collaborators, I was able to, and I actually just found out earlier this week that the paper was accepted in psych services. Appreciate the happy dance, Eric. So there are a couple different ways to define adequate care. So one of the more typical ways to define adequate care is by using some definition of minimally adequate treatment. And so one common way that has been operationalized is as 4 or more mental health visits with any mental health care provider, plus medication, or if there's no medication, then at least 8 visits. And I think this is a potentially great way to analyze data quickly, to sort of quickly categorize kids' care, but it doesn't really allow for adjustments for clinical characteristics like comorbidity or severity. What has been found in the past using this definition, the minimally adequate treatment definition, is that Black and Hispanic youth were less likely than white youth to receive minimally adequate treatment. And having a more severe presentation was associated with an increased likelihood of receiving minimally adequate treatment. But again, doesn't really get at the quality of care or allow for flexibility by diagnosis, comorbidity, patient age, et cetera. So I wanted to look at things a little bit differently. So I used an expert consensus approach, which allowed us to consider the appropriateness of different medication therapies and the comprehensiveness of care given a child's profile of comorbidities. We made these judgments based on recently published practice guidelines and recommendations. And the strategy included independent ratings by 2 licensed clinicians. So I've been saying we, so I mean myself actually, and Dr. Bob Findling, who is the chair of psychiatry at VCU. So we each independently rated, we reviewed all of the LANS kids' baseline service use data and rated their treatment as adequate or not. So we rated the adequacy of their treatment and independently. And when we didn't agree, we had a consensus meeting to discuss any discrepant ratings. So this approach allowed us the ability to fully utilize all of the information available to make determinations about patients' treatment status. It allowed us some flexibility to take into consideration their comorbidities, their age, other clinical and treatment characteristics, including things like recent inpatient hospitalization discharge. And it utilized expert knowledge of 2 clinicians with complementary expertise, myself being a psychologist and Bob Findling being a psychiatrist. So one thing that's important to note is that, so we were reviewing their service use as was reported at the baseline interview. So remember that these kids were all recruited during a screen visit. That was their first visit to one of 9 outpatient clinics. On average, the time between screen and baseline was a mean of about 45 days. So that means on average, by the time we were looking at their service use record, they had been known as needing care. They had been in contact with a mental health clinic for a mean of 45 days, so about a month and a half. So we rated their treatment as standard of care. So we initially rated both medication and therapy as standard of care. So in that case, it would be treatment that was consistent with published treatment guidelines without any clear evidence of missing components. Adequate would have been a treatment for primary diagnosis that was consistent with treatment guidelines, and a secondary or perhaps less severe diagnosis that was partially treated without any inappropriate or contraindicated treatments. Or it could mean partial treatment received for an NOS diagnosis. Inadequate would be that there was a treatment component that was indicated but missing. An inappropriate rating would mean that at least one component of the treatment provided was contraindicated, or there was polypharmacy that was not consistent with treatment guidelines. And then the last group was treatment pending. And this was kids for whom their diagnoses seemed to warrant treatment, and there was evidence that it was forthcoming but had not yet begun. So these kids might have had an evaluation or an intake, but there was no active treatment. Ultimately, we collapsed these groups into adequate and inappropriate, or adequate and inadequate or inappropriate, because what I was really concerned about was, are kids getting adequate care, yes or no? And so it made sense to collapse across groups. One thing that I will note, I told you before that there was a mean of 45 days between that screen and baseline assessment, the baseline assessment being the point at which we were rating their treatment adequacy. That amount of time did not differ among these 5 groups. So the kids in the treatment pending group on average had been in contact with a clinic for the same amount of time, or not a non-significantly different amount of time for as the kids who were in the standard of care group. Unfortunately, there ended up being very little variability in the treatment ratings for psychotherapy, because caregivers often didn't report psychotherapy treatment modalities, maybe because they didn't know, or maybe the providers never told them what psychotherapy modality they were using. And there's good evidence to suggest that providers often don't actually do what they say they're doing anyway. So we ultimately focused our analyses on the adequacy of medication. I will say, though, that we did not completely ignore the psychotherapy data. So we used the psychotherapy data to inform our ratings for medications. For instance, if there was a child with an NOS diagnosis, say a child with depression and NOS who was receiving psychotherapy, but they weren't receiving medication, we would still rated their medication adequacy as adequate because they were receiving some treatment for their NOS diagnosis. Okay, so this is just looking at participant characteristics by group. Again, there's a lot of information here, but in the end, we had enough data to look at for 687 of the kids and LAMs. The sample was mostly male, mostly white, with 25% of the sample was Black, and about half had Medicaid insurance, so there was good socioeconomic diversity. Most of the caregivers had not completed college. The most prevalent diagnosis, as I mentioned before, was ADHD, and about 22% have a bipolar spectrum disorder. So again, we wanted to know what was associated with receiving adequate care early in treatment. So similar to our previous research, we found that race was associated with receiving adequate care. I'm going to show you this slide quickly, and then I'll describe a little bit more what you're looking at. Parents, caregivers' education was also associated with treatment adequacy, and anxiety was associated with treatment adequacy. So overall, only 53% of kids had received adequate medication for their diagnoses. So again, these are, you've probably heard numbers from epidemiological studies before saying, 50% of kids who need care actually get some sort of mental health care. So these kids in this study, just to reorient you briefly to the LAMP sample, these were all help seekers. So they all had gotten to the point of actually seeking care. And at that point, only 53% were receiving adequate medication for their diagnoses, which to me is not satisfactory. Youth whose caregivers had a bachelor's degree or more education were more likely to receive adequate care, which is consistent with prior research. Youth with anxiety were less likely to receive adequate care. I wasn't super sure what that was about, but perhaps anxiety diagnoses are unrecognized or underdiagnosed by treating providers, or it's possible that caregivers might be resistant to indicated interventions for anxiety disorders. But consistent with our hypotheses, Black youth were less likely than white youth to receive adequate care. Now, white youth and youth who identified as American Indian or Alaska Native, Asian, or bi-multiracial did not significantly differ in likelihood of receiving adequate care. But that could be just because that was a pretty heterogeneous group that we ended up collapsing into one group because there would be small cell sizes if we had left them as individual groups. But these effects, the Black youth being less likely than white youth to receive adequate care, persisted with adjustments for Medicaid status, caregiver education. So again, this is not due to socioeconomic status or cannot be explained by socioeconomic status. Also persisted with adjustment for clinical characteristics. And I'm probably starting to sound like a broken record, but racial disparities in access to mental health care are well established. They might originate from the things we talked about before, inequitably distributed financial or logistical barriers or systemic barriers. And to me, this really highlights the need for further provider training and cultural humility, reflection on their own biases. Again, these kids were all in contact with the mental health care center, but not receiving adequate care for some reason. But we also need to work on developing more accessible interventions. I do want to highlight some limitations of these findings. So I think any definition of adequate care is going to have some significant limitations. And to me, one of the most significant limitations of these definitions, including my own, the one that we used in the study that I just described, is that they're not nuanced enough to capture patient and family autonomy. So in my opinion, any care, even if it's sort of deemed the gold standard, is really going to be inadequate if the planning of it doesn't take into account a family's concerns, preferences, and treatment barriers. And again, I'm going to talk to you in a little bit about a tool for how to assess those things. So again, the work that I've just described replicates racial disparities found in prior research, and there indicates a clear need for new strategies to reduce barriers and bias, because I think collectively highlight the need for both systemic change to reduce access to care barriers, and also for providers to carefully reflect on their own bias and the complex and long history of medical harm and health disparities that might contribute to medical mistrust. We've had lots of different sort of policy changes and things like that, but these problems aren't improving. So let's talk a little bit more about possible solutions. So I want to return, so earlier I described this quote that my mother shared with me about challenges in seeking mental health care for the kids in my family when we were kids. And she said, again, our history is such that if there is a problem, especially with your child, you use the tools you have, especially if you're not sure if seeking professional help is going to do more harm than good. So I want to shift now to talking about how we can make sure we do more good. So I want to briefly mention policy changes. I know policy changes get talked about a lot, and I definitely think that there are things at the policy level that can help, including making treatment more affordable, increasing access to insurance, and incentivizing mental health practice in underserved areas. But I really want to spend more time focused on possible solutions that can be driven by mental health care providers. I've mentioned before that the causes of disparities in mental health are many and varied, and so I think the solutions also must be varied. many. So I want to talk about how we define evidence-based practice. So one potential reason for racial ethnic disparities, one potential reason that has been posed by the articles that I've cited here and that I agree with, for disparities in treatment outcomes, is the samples that we use to define, the samples that are in the studies that we use to define evidence-based practice. So we use the results of randomized controlled trials to define what constitutes evidence-based practices. But if you look at who's participating in randomized controlled trials, they're predominantly white and middle-class families, which to me begs the question, for whom are practices evidence-based? We often don't really know about how well a particular treatment works across different racial ethnic groups, across socioeconomic status. One solution that has been developed to help address this treatment gap are culturally adapted versions of evidence-based treatments. And some culturally adapted interventions have shown benefit over the traditional evidence-based treatments or waitlist control. Others have found mixed results. And currently, although that doesn't mean that it won't happen, it certainly can happen, but currently there aren't any treatments, any culturally adapted versions of evidence-based treatments that are well established for racially minoritized youth. There's also been some evidence that in some cases the standard evidence-based treatments might work better than the adapted version. So we just need to sort of better understand how these are working when they're working. But I do want to highlight that cultural adaptations can present some significant dissemination barriers. And again, these have been highlighted, these concerns have been highlighted by the folks that I'm citing here as well. And one of the barriers is that it necessitates that providers know whatever the culturally relevant version of the interventions they're delivering are for each of their patients. And if you work in a community mental health center, that could mean clients from multiple different cultural backgrounds. The other thing about cultural adaptations is that they don't allow for individuality within racial groups. So one alternative or another solution that's been proposed, and one that I like, is using a person-centered approach. So when I talk about person-centered approaches, I mean showing empathy and unconditional positive regard for the youth and the families that we work with, a recognition that each individual has their own identity, their own needs, their own preferences. And one way to assess this is the cultural formulation interview, the CFI. And this is a lot of information on the slide that I'm not going to go over in detail, but the CFI is a tool that can be used at an intake assessment during an evaluation that helps to assess the family's cultural definition of the problem, so how they would describe it in their own words, how people in their community would describe the problems that they're having, how they would describe the causes and contexts of the problems, and what sort of supports they've already been able to establish for helping with those problems, cultural factors that might affect self-coping and past help seeking. So assessing their current coping strategies, broadly assessing their experience with help seeking. So not just looking at the typical ways that we often ask about past help seeking, but also asking about things like folk healing, informal counseling, religious or spiritual counseling. So having a sort of broad discussion about the kinds of strategies that have the kinds of help that they've sought in the past and barriers that they've experienced. And asking about cultural factors affecting current help seeking. So again, I mentioned preferences, knowing what the family's preferences are might be important, what people in their network have recommended for addressing the problem, and what concerns they might have about the current clinician and patient relationship and barriers they might have to accessing care and staying in treatment. You know, we spend a lot of time in our assessments. Typically, we're very sort of like symptom focused, and we're very focused on the ways that we as clinicians have been taught to identify problems. And that's important. We need, you know, to have a diagnosis. We need it for billing. We need it, you know, to help with treatment planning. But I think having this more nuanced discussion with families about how their own experience of the problem and how sort of using their own words and language to describe the problem, I think can help them feel more engaged. And it's actually not just my thought. There's actually some research to back this up, thankfully. So Amanda Sanchez and her colleagues took a look in a randomized controlled trial at how the CFI, the cultural formulation interview, can improve treatment engagement. And so what they did was they had a sample of youth with behavioral problems, most of whom identified with a racially minoritized group. And they randomized them to receive assessment as usual or assessment as usual augmented with the cultural formulation interview, which again is this brief caregiver assessment of cultural values that might affect the child's problems and family health seeking. After the intake assessment, patients were offered a course of PCIT, or parent-child interaction therapy, which is a well-supported behavioral parenting intervention for child behavior problems and maladaptive family patterns. And what they found was that this person-centered assessment, so adding the CFI to their assessment at intake, was associated with provider and caregiver satisfaction, better provider understanding of the patient and family, and improved patient and family engagement and treatment. So taking the time to understand in their own words how folks are experiencing the problem that they come to the clinic with, what they feel like would be helpful, what's been helpful to them in the past, helps to improve the experience, the treatment experience for both the provider and the family. And having a cultural formulation can also help to set the groundwork, provide important context for discussions, race-related or culture-related discussions later on. So one point that I'd like to highlight, and other people like Sharday Galan and others have done this very well. One thing I want to highlight is that the conversation can't just be it often shouldn't just be a one-time thing. So oftentimes, particularly recently, there have been sort of high-profile racism-related events that have come up that patients might want to come to us to process. And if you've already done this sort of cultural formulation, if you've already sort of established your office as a safe place to talk about these experiences, then that will help to facilitate those discussions and help you to better assess how your patient and family might be managing with these sort of high-profile racism-related events. I'm running out of time, so I'm going to talk about a few other things very briefly. But I think another important thing to think about is the workforce diversity. So this figure is taken from the APA website. And the bottom bar is the racial distribution, racial and ethnic distribution of the US population. So 5% Asian, 12% Black, 18% Hispanic, 62% white. And the top bar here is the US psychology workforce. And so you can see that Black and Hispanic or Latino providers our psychologists are underrepresented in the workforce and are even slightly more underrepresented in the health service psychology workforce. So why is workforce diversity important? There's lots of reasons. There's evidence of provider bias influencing clinical decision-making. Mental health treatment might be more susceptible to provider bias as compared to other disciplines because decisions about treatment access, diagnosis, and disposition are often made by a single provider compared to team-based approaches of many other disciplines. And there's research showing that Black and Latino providers may show greater cultural competency and maybe less likely to display racial bias. And what I'm not advocating for is, I think, yes, we should have a more diverse workforce, but I'm not saying that we need to have that so that we can always provide sort of one-to-one, have race matching in every case. I think that it's a mistake to assume that because people are the same race, they share the same values or have the same experience of their culture. But having a more diverse workforce increases the creativity. There's research showing that increases creativity in the workplace, it increases productivity, and it reduces turnover. It creates a better environment for everyone. And I can also say anecdotally that as a provider, I have gone into the waiting room to get a patient and had a family that was not the family that I was there to see stop me and ask if I worked there. And say, "Are you a doctor? Do you work here?" And be relieved to know that there was a Black provider there, even if I wasn't the one who was treating them. So seeing representation in the space, whether the provider is whether myself as a Black provider was the one that was treating the family, again, anecdotally has seemed to make folks feel more comfortable about seeking treatment in that space. I just want to briefly say, I talked to you a little about myself as a 9-year-old girl with OCD, and I'm grown up now, and I'm really honored to be in the position as a dean. I'm the assistant dean for graduate biomedical education and graduate student diversity in the School of Medicine here at Hopkins, and I'm in a position to help improve workforce diversity. And I'm really grateful for the opportunity to think more about diversity and in the biomedical workforce. But here is a picture of me. I'm the one right there in front in the black dress with a group of students and some of my colleagues after an event that our students put together. So our more senior students put together for the incoming students, called the hidden curriculum event, which was an event designed to so if you're not familiar with the hidden curriculum, is this idea that there are skills, there are non-cognitive skills and tools that are inequitably distributed that are really necessary to be successful in graduate school. And so the goal of this event was to share those tools and skills with our incoming students who identified as members of groups historically underrepresented in science. And I know they had lots of fun and found it very, very helpful. I'm going to skip over this in the interest of time, but I've also been really excited. I know Dissect, which is a group that originated from HGAPS, it's dismantling systemic shortcomings in education and clinical training, is a graduate student-led organization that's also been striving to create, collate, and disseminate open access resources to measure, assess, evaluate, and advance anti-racist initiatives in clinical psychology and related graduate training programs. And I know they've also been creating a toolkit to help provide information again about that hidden curriculum. And the last thing that I want to say, that I want to highlight, is that I've been lucky enough to get to co-guest edit a special issue in the journal Clinical Child and Adolescent Psychology on advancing racial justice in clinical child and adolescent psychology with my co-guest editor, Noelle Hurd, whose picture you can see there. And it should be coming out in the next couple of months, which is really exciting. But the issue is focused on 3 areas that we think hold the potential to reduce inequitable treatment of children and adolescents of color, including strategies to address structural barriers that disproportionately impact youth of color, approaches to increase representation of mental health care providers of color, like we've just been talking about, and providing culturally responsive care. And I think we really have to adopt an anti-racist approach to treatment and education that acknowledges racial trauma and provides trainees and clinicians with education on the mental health impacts of racial trauma and strategies to prevent and treat associated psychological distress. So as I've said before, the causes of racial disparities are varied, and so we have to come up with lots of different solutions to tackle it. I'm going to skip this because I think I've summarized, but I also just want to say thank you to my many collaborators, and thank you again to y'all for having me here. And I want to make sure that I leave a few minutes for questions.
So thank you, Dr. Young. This was a fantastic talk. I learned new things a couple times that I facepalmed. I was like, oh, didn't know that. And the exciting material, things that we could use in our clinics here, that we could help share with other people, and ways that we could work together to change policy to really improve things in 2023 and going forward. So thank you all for coming. Thank you, Julia and Phoebe and the Student Government Association, for the University of North Carolina at Chapel Hill for making this event possible. One more round of applause if you're at a place that you can unmute. Woo! Clap with me or put up, raise hands. Yeah, this was great. Thank you a ton. And in an HGAPS tradition, welcome to the after party.